Our luncheon speaker today is provided to us by Anthem, and I want to thank Jeff Ricketts, who serves on our board, for his leadership and for their sponsorship and support of the Chamber and all we do throughout the year. And they have been our main sponsor and presenting sponsor since for the last 8 years. I also want to say we're fortunate to have their Director of Medical Health for the nation here with us on behavioral health. This is an individual I've gotten a chance to know just a little bit this morning, although we spoke on the phone quite a bit before he flew in. I told him I knew he was an expert, and he said, why? I said, because you're flying in from out of state. I know you're an expert. So I'm looking forward to hearing you. But he leads substance use disorders and is a medical director for Anthem on this opioid initiative and drives their strategy. He is uniquely qualified as a physician and as a psychiatrist and has practiced medicine in both areas. He's a graduate of the Medical School of India as well as psychiatric residency at the University of Illinois in Chicago. We're very fortunate. We're looking forward to hearing kind of a global view from him to wrap up all the things that we've heard today and sort of chart the course going forward as to Anthem's view of how we can be most productive to create a brighter future for all of us in this area. Please join me in welcoming our keynote speaker for lunch, Dr. Raina. Thank you very much for being here.
That was a great morning today. Fantastic discussions, fantastic panel discussions, and as that was going on, I was wondering, how am I going to follow up on that? How am I going to follow up on that? And unfortunately, the decision was already made by Barry and the chamber here because I had to submit my slides a week ago. So I'm going to do what I'm going to use the same slides, whatever I had prepared, and hopefully you will still find the information I have to share with you useful and complementary to what you learned this morning already. I want to start out by mentioning something that, the economic costs of substance abuse are hard to calculate. And partly they're hard to calculate because the direct costs of treating substance abuse are actually very easy to calculate. That part is not very hard. That part, how much do we pay for when somebody goes for addiction treatment? That part is very easy to calculate. But what about the overall cost in terms of the substance use having an impact on criminal activity, substance use having an impact on the justice system, substance use having an impact on productivity, which is the health of the workforce? That part is not very easy to calculate, and you have to sort of look at many different sources to find that information and to collect that information and put it together. So the data that I will share with you about, the economic costs of substance abuse will be something that, it's not just from one source, all the data, and some of it is from, different sources put together and the best guesstimates that people have made. But then what we'll do in today's presentation is I'll go over the economic costs of substance abuse globally for the US, and then kind of zoom in on Virginia. And then we'll also look at the impact of the opiate crisis globally for the US, and then on Virginia again. Okay. Now, but before we go there even, there are a few statistics that are worth keeping in mind. As of today, every 12.5 minutes, somebody dies from a drug overdose in the US. Every 12.5 minutes, we lose somebody from drug overdose in the US. So that's something that's where I want to start with. It's about economic costs, but it's also about tremendous human costs. So let's start with when we talk about the economic costs of substance abuse. I know we've been discussing mainly focused on the opiate epidemic today. And Dr. Trestman, I think from Carilion Clinic mentioned, let's not forget about alcohol. And take a look at how economic costs are divided in the US. Annually, we spend, $1 billion on substance abuse. Most of it is actually 80% of it, slightly more than 80% of it is is crime and lost productivity related costs. Only about 20% of it is healthcare related cost. And then when you look at, okay, what are the substances that are responsible for these costs? So you have tobacco is still number one, despite the fact that less than 20% of the population of the US now smokes cigarettes. But tobacco is still number one. Why is that? Because tobacco affects a lot of other conditions. We typically think of tobacco as something that is responsible for lung cancer. But it's not just responsible for lung cancer. It's responsible for about 30% of deaths related to heart disease, about 30% of deaths related to emphysema, about 30%. And it also plays a part in increasing risk of 14 other cancers besides lung cancers. So it's not just the lung cancer. So tobacco still remains number one. Then you have alcohol at number two, prescription opioids at number three, and you have illicit drugs at number four. And just compare how tobacco and alcohol compare, the legal drugs compare with the prescription opioids and the illegal drugs. So and again, we're talking about the direct economic cost here. Direct impact of substance abuse on employers is, tardiness, absenteeism, presenteeism, employee turnover, theft. This is something that we don't frequently think about, but this is something that happens in our homes too. When we have somebody who has an addiction who's in our home, you'll find that, suddenly, silverware starts going missing from home, that kind of stuff. And you will see things missing from home. But this happens at work too. Theft of actual property or embezzlement and those kinds of things start happening in businesses. And then of course conflict between, by some accounts, the number one reason for conflict between employees in a workplace is when one of those employees has a substance use issue. And of course all of that translates to greenbacks. I want to thank Kim McKay from the chamber here for helping me put this together. This is what Dr. Hughes Melton shared earlier too. So in terms of and I apologize for the formatting there on the bar chart there. So you can, if you are a Virginia employer, if you're actually employer anywhere, you can go to this website, the National Safety Council's website, and you can put in how many employees you have, what type of business you have, and it will give you an estimate of what's the estimated cost of substance use in your workforce based on what we know about how many people typically in that industry have, as far as addiction is concerned, what are addiction rates in that industry, and what are the costs in that industry of having addiction. So using using the National Safety Council's information, this is the data you come up with for Virginia, which is that you have about 1.4 million in cost for substance abuse total. This is again direct economic costs, and then of those you can divide that into about half, about 500 million is for job turnover and retraining, then lost time, and of course healthcare is about 363 million. Once again, healthcare, if you pay attention to both the graphs that we've seen so far, healthcare remains a small part of the total economic cost. This is again, we're just talking about the direct economic cost. Let's talk about the indirect economic cost to employers of substance use disorders. You have a reduction in the pool of potential employees. We heard that, somewhere that you have people now testing positive, so many people in some states, there's so many people failing pre-employment drug screening that up to 20% of potential job applicants cannot be hired because of that, because they're failing pre-employment drug screening. Reduction in customer base. and then reduction in taxpayer base in the community. And why is that? And take a look here. This is our take a look at the next graph. We're talking about drug overdose rates here, but they apply, this issue applies to all sorts of addictions, not just to drug overdose. But drug overdose is a way to sort of look at this and get a sense of this quickly. So when we're looking at this by age group, look at in which age groups are the drug overdose rates the highest. It's the most productive, the most productive years of a person's life. The drug overdose rates are the lowest for the people who are 15 to 24 and the people who are 65 and over. Everywhere else, that's where the drug overdose rates are the highest and they're peaking the most. That goes back to what I was saying in terms of indirect costs, which have not been taken into account in those graphs that I showed you, which is reduction in the potential pool of employees, reduction in potential pool of customers, reduction in, because if they're spending their money and time and resources on things that they're addicted to, they're not buying the goods and services that the Virginia manufacturers are apart from healthcare services, of course, they're not buying other goods and services that you want to sell to them. The economic cost of the opiate epidemic has been particularly hard to calculate because of its impact. First of all, I think for the longest time, people were not measuring it in a proper way. There were not a lot of people trying to measure it. So a healthcare consultancy firm called Alterum recently published this data, and they said that the economic cost of the opiate epidemic since 2001 has been $1 trillion across the country. They also published this map which shows the relative economic burden of state by state compared to the average state. So if you take the $1 trillion and then you'd make, say divided by 50, what would be average for each state? And then according to that, some states are gonna be higher. So 1 is basically the average state, and 1.8 is, basically 80% higher than the average state, and 0.4 is, 60% lower than the average state. As you see, Virginia is sort of, it's lower slightly. It's just about 1. It's just about at the average state. It's actually relative cost is 0.92. So it's just about at the average state. So, and it's surrounded by, it borders states that are significantly worse. So if you don't, and in some ways that map is a warning call, is a caution to folks in Virginia, to you guys, to community and business leaders here, that if you're not being proactive about this, even at this stage, what you see in West Virginia, what you see in Maryland, that could very easily be you. Let's zoom out again now to the deaths caused by substance use disorders. And this again is another way, this is not telling us the economic cost, this is telling us the human cost. The human cost of addictions. Once again, take a look at the pie chart, and the 75% of the pie is occupied by tobacco. Alcohol takes about 14% of the pie. The other drugs basically take about 10%. And of those other drugs, prescription opioids are 3%, heroin is 2%, fentanyl is 3%, and so you basically are looking at now so we've spent most of our day today talking about the drugs that affect 2 and 3 and basically 5% of the human cost. And a relatively small percent, not so small, but relatively small percent of the economic cost as well. So my point with sharing this and sort of zooming out in this way is not to say that we shouldn't be doing everything that we're doing right now to address the opioid epidemic. It is a real crisis. It has led to, for the first time in decades, it has led to life expectancy falling in the United States 2 years in a row. For the first time in decades, now we have the latest information that came out last week, which was that for the age group 25 to 34, 1 in 5 deaths opioids are involved in 1 in 5 deaths. So that's 20% of deaths are accounted for by opioids. Now, so it is a serious issue. People die young with this addiction, with the opioid crisis. So we have to pay attention to this, and we have to respond to it in a way that we are responding in a crisis mode. But the important point that I'm trying to make is, let's not forget that when we are just responding to one drug or another, we are responding to only that drug. We're responding to, in some ways, to a symptom of addiction as a disease. We are not responding to addiction as a disease as a whole. So what has that, and when we talk about, we're responding to one drug or another, this has led to 3 waves of opiate deaths in the US, for example. So the first wave started off, typically when people talk about the opiate epidemic, prescription drug epidemic started in 1999. That's how people think about it. I think it started a little earlier than that, probably 1996, when pain as the 5th vital sign was incorporated by Joint Commission as one of the standards that they were going to measure healthcare facilities on. So that's when it started. But let's take it at 1999. What happened in 2010 that it suddenly became from going from a prescription drug being the main cause, the heroin deaths started to rise and peaked, and ultimately crossed the prescription drug deaths. It was because in October 2010, the manufacturer of OxyContin, which was the famous villain in this saga, came up with their preparation that could not be abused as easily. So they came up with a preparation that could not be abused as easily, and we get a heroin epidemic. So that's what I mean when I say that we have to look at treating addiction as a disease, not just in the individual, but the addiction as a population health level also, not just get too distracted by the newest villain in the story. Because in the US, what has happened as we have done this is every time a heroin epidemic has been followed by a cocaine epidemic, which has been followed by a heroin epidemic, which has been followed by a cocaine epidemic, and that's what keeps happening. Because we just keep switching. And then eventually, in 2012, fentanyl and its, what I call analogs, or chemical sisters, basically, so to speak. Fentanyl and its sisters entered the drug stream, and now we have them responsible for the greatest number of deaths, because they're much more potent. They're about anywhere from 1,000 times to 10,000 times more potent than morphine. So what does this mean in terms of drug overdose rates in Virginia? They have gone in the same time period from 2.7 per 100,000 Virginians to 13 per 100,000 Virginians. Now this graph that you see, it's the aggregate drug overdose rate. Now, in most states, about 50% of drug overdoses are accounted for by opioids. In Virginia, we heard that that's not the case, because Dr. Melton said earlier that out of the 1,500 or 1,400 deaths, about 1,200 were, opioids were involved in about 1,200. So in Virginia, this is actually worse than nationally. In terms of the economic and human cost, also, of course, you're looking at, according to CDC, about 26 ER visits for each fatal drug overdose death. There are 26 drug-related ER visits. Now just think about that in terms of what impact that has on the economic costs, on people, and human cost. And when I say human cost, it's not just in terms of the patients, individuals who are suffering from addiction, but what it does to the healthcare providers who treat these patients. How pessimistic, how it changes their perception of human condition and human behavior. So what's the way out? The way out of the epidemic is basically going to be these 3 things: prevention, treatment and recovery, and deterrence. And by prevention, we have to figure out, and I think most of the country is well along on these 2 things that I have said here, which is reduce prolonged exposure to prescription opioids. Studies have shown that it's not, even though, we talked about MME, somebody was mentioning this in a panel earlier, even though the CDC came with the guidance that you should, there shouldn't be no good reason for people to go over 90 morphine milligram equivalents of any opioid when they're being treated with prescription opioids. The fact remains that it's not the dose that matters as much, it's the duration for which somebody is treated for opioids. There was a study that came out of Britain earlier this year in which they looked at 500,000 people who had been prescribed opioids and found that for in the first 2 weeks of being prescribed opioids, it didn't matter. There was no greater risk of addiction. It didn't matter what dose they were given, all of that stuff. It didn't matter. But after that, for every 10 milligram increase of morphine milligram equivalent, there was a 1% increase in risk of addiction. But for every extra week of treatment with opioids, there was a 20% increase in risk of addiction. So it's not the dose that is that matters as much as the duration of treatment. So it's the prolonged exposure, we're trying to cut that. And then, of course, reduce the availability of opioids. I think the doctor from Ortho Virginia had mentioned that how we have people used to get prescriptions for 30 pills, when they don't really need 30 pills. So let's cut, and most places are starting to cut that. Then we have to improve access to evidence-based treatment. A lot has been said about this as well. But before I actually go any further on this, I want to ask the group here, if people had to guess as to what's the best time in a person's life to do any kind of preventive work regarding addiction, what age would be the best age at which to intervene? In terms of a cost, in terms of say a return on investment basis. In terms of a return on investment basis. Any guesses? But before they're born? 6. 12. And who says before 6 years of age? How many say 6 to 10 years of age? Okay, so all answers are good. I think people talk about early intervention in middle school and high school. That's actually already too late. The Surgeon General came with a report on facing addiction in America in 2016, and they had a list of evidence-based interventions and early interventions and their return on investment. The return on investment was highest for an intervention called the good behavior game that is done with kids in 1st and 2nd grade. That game just is done with their teachers. It doesn't teach anything about addiction at all. It actually teaches life skills, delaying gratification, waiting for your turn, that kind of stuff. And that has an ROI of 64-1. So when we talk about interventions and what the business community can be doing to advocate for things, we should be looking for early interventions. With those kinds of ROIs, those are amazing. Okay, so deterrence, we talk about, stopping bad actors, so the next question is I would be remiss if I didn't say something about what Anthem is doing. Okay, so what Anthem is doing on this front. So we're doing the same three things, same three categories of things. We are educating providers. We have put in hard edits for prescription opioids for what are called opioid naive patients. So if you are an individual who has never received an opioid before for anything, prescription opioid before for anything, and your doctor writes you a prescription for 30 days, sorry, we're going to only we're going to allow it to be filled only for 7 days. Now, if your doctor believes that you need more than that, they'll have to complete a prior authorization, and you can still bypass that. It's not like you cannot get more than that. But if you've never received opioids before, 7 days is it, no matter what the dose. And that has shown results. And this is what it has shown in Virginia for all three lines of business that we have, for commercial, and Medicare and Medicaid. In all three lines of business, even though nationally we had set our goal that we want to reduce our opioid prescribing for short-acting opioids for opioid-naive patients by 35%, Virginia is way ahead at 50% on all of those lines of business for Anthem, Virginia. So we also want to, in terms of treatment and recovery, and somebody earlier had talked from Optima had talked about lock-in program. We don't call it lock-in, we call it pharmacy home program, which is basically making sure that for members we see as showing signs in their data of potentially misusing opioids, we put them to one pharmacy and one prescriber. They cannot get it from multiple pharmacies and multiple prescribers. We're trying to expand quality medication-assisted treatment, meaning medication-assisted treatment that combines not just medications like methadone and Suboxone, but with therapy, so comprehensive treatment. We're trying to work with various vendors who are trying to do amazing things like have software programs that will, smartphone-based apps, for example, that will predict when somebody is likely to stop their pro-recovery behaviors. So we can, we're trying to work with those. We are also collaborating with advocacy organizations. You might have heard the name Shatterproof, Facing Addiction. We are collaborating with them, trying to come up with standards standards for substance abuse treatment programs. Because right now, substance abuse treatment programs don't have any standards against which they're measured. There are a lot of substance abuse treatment programs that don't do evidence-based treatment. So we're trying to come up with standards based with advocacy organizations. And then, of course, we're doing provider education regarding inappropriate prescribing practices and also trying to identify from our data when we believe that somebody may be running a pill mill, for example, and report, investigate them. What else are we doing? We also removed prior authorization for Suboxone more than a year ago. We committed publicly to doubling the percentage of our opiate-addicted members who are getting quality medication-assisted treatment. Now, that was a stretch goal for us. We knew this is a challenge because there are not enough providers doing this, so we are trying to work with what is called Project Echo to try to improve the capabilities of primary care providers, your general physicians, to treat opiate addiction using medication-assisted treatment. This has all been led by an Anthem, by an opioid strategy work group that has been in place for more than 2 years now. Finally, the question that should be on everybody's minds, and every so often is on everybody's mind, why not just ban all opioids? Well, opioids do have a role in legitimate, treatment, not just of cancer, but also of certain debilitating non-cancer pain. They do have a role there. And inadequately treated pain also has a cost, also has economic costs. So we do not want to completely ban them, but you definitely want to be prescribing a lot less of them than we have. All hands on deck. I say, this is at this time, everybody needs to be on board with doing all of these things. And I will leave, before I go to my last slide, and I wanna say something about stigma. When we talk about addiction as three manifestations of addiction being treated as a stigma, I'm gonna share with you. One is, for Suboxone, doctors have to get a special training and a special license to prescribe it. It is an opioid that is used to treat opiate addiction. But you don't need special training and special license to prescribe opioids. And there is a limit on how many patients you can treat with Suboxone. You don't have any such limit on how many patients you can treat with OxyContin. So that's an example of the stigma. We're all in this together. We cannot forget this. Blue Cross Blue Shield of Massachusetts did a survey a couple of years ago. They found essentially that 56% of their members knew someone addicted to opioids, 45% knew someone who had overdosed on opioids, and 27% knew somebody who had died from an overdose on opioids. Pew Research did a survey last year where basically 46% of Americans admitted in that survey to having a friend or a family member with a past or current drug addiction. And look at that, it cuts across, no matter how you cut it, gender, age, race, political divide, no matter how you cut it, it's about the same. So what I want to say to you, the message that I want to leave you with is, there were amazing panelists this morning that shared with you a lot of what is being done and what is happening to try to address the opioid epidemic. And we have to do everything that we can, but don't lose sight of the fact that there is a human cost and an economic cost associated with other addictions that is greater than with opioids. Thank you.